This conference will now be recorded.
Good afternoon. My theme today is self-care and palliative care, the Pathways model. I'd like to begin by greeting all of you there at Palliative Care 2019 in Prague. Greetings from Saybrook University in Pasadena, California. The Pathways model was developed by my colleague Angel McGrady and I in 2 books, Pathways to Illness, Pathways to Health, and a second one focused on chronic illness and palliative care. The second book is called Integrative Pathways. The Pathways model addresses the continuum of health and disease and the role of health risk behaviors and self-care in shaping the person's overall health. The model assesses where the person is on the continuum and identifies current levels of health deficiencies or disease. This is John Travis's illness-wellness continuum. Traditional biomedical treatment is focused on the illness end of the spectrum. We are going to be focusing on eliminate negative health risk behaviors, which are on the left side of the continuum, but also building positive awareness, educating for self-care skills, and guiding people to the higher level end of the spectrum. The Pathways model combines interventions at 3 different levels to actively engage human beings in their own self-care. Level 1 includes self-directed behavioral changes, lifestyle changes, including such things as increased activity, improving sleep, and self-guided nutritional change. Level 1 interventions tend to restore basic biological rhythms. Level 2 includes acquisition of adaptive coping skills and additional self-care with the assistance of educational resources and community-based supports. Examples include learning mindfulness skills, progressive muscle relaxation, or hatha yoga, using educational CDs, apps, or community-based classes. Level 3 includes the use of professionally delivered evidence-based treatments, including such things as biofeedback, hypnosis, medical care, medication, spiritual counseling, and therapeutic massage. An individual may suffer from a chronic condition, even a terminal illness, and still pursue goals related to higher level wellness. Persons with diabetes, heart disease, and cancer still respond to new skills, spiritual practices, and increased social engagement with a reduction in suffering and an enhancement in meaning in their lives. We may apply the related skills at all 3 levels. For example, mindfulness, a patient may undertake simple mindful breathing as self-care after an in-office demonstration of mindful breathing. At level 2, the person might choose mindfulness training based on a community-based class or using a Jon Kabat-Zinn educational CD. And then at level 3, the patient may receive mindfulness-based stress reduction or acceptance and commitment therapy based on mindfulness provided by trained therapists. The emphasis on self-care is timely, as the World Health Organization just released consolidated guidelines on self-care interventions for health. This is their definition of self-care. Self-care is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a healthcare provider. We personalize care in the Pathway model using a coaching process. We establish a collaborative alliance with the patient for health. We identify with the patient in a dialogue their needs, their readiness for change, their personal goals at each level, and follow through is optimal when the patient sets their own goals with autonomy and has a sense of owning the goals themselves. The coaching process matches the level and type of intervention to the person's goals, needs, motivation, and resources. Level 1 includes such things as mindful breathing, nutrition and feeding behavior, sleep and rest, and simple movement. That's not the same as exercise, working out in a gym. Rather, simple movement typically means walking short distances or even moving with music. Level 2 interventions include such things as progressive relaxation, alternately tightening and relaxing specific muscle groups to enhance awareness of muscle tension and control and the ability to relax the musculature. Now, at level 2, we move toward exercise, beginning with simple exercise, stretching, or slow walking, and then increasing the distance and speed of the walk. At level 2, we also use a variety of meditation practices. Mindfulness training is another example of a level 2 intervention, as is the idea of a pause, a mindful moment of awareness in which I pause and consider what is happening, what is my optimal response before I respond to the stressful situation. Level 2 interventions using community resources include such things as gentle yoga, designed for people with painful joints and restricted movement, so it proceeds more gently. Tai Chi and Qigong, both of which are simple, graceful movement disciplines, and aquatherapy, undertaking guided exercise in a warm heated pool, which relaxes the musculature and enables movement with less pain. And the water, the flotation, also reduces impact on the joints. Level 3 interventions run from biofeedback, relaxation therapy, through clinical hypnosis, psychotherapy, and strategic pharmacology, medical management of conditions. At level 3, we also draw on complementary and alternative therapies and spiritually based practices, such things as acupuncture, Reiki energy healing, functional medicine, functional nutrition, Feldenkrais method, and Hanna somatic body work. We also draw on spiritually based practices, since illness, especially chronic illness, frequently awakens spiritual needs and spiritual anguish. Spiritually based practices include prayer, healing circles, spiritual imagery, pastoral counseling, and retreats. I'm going to switch now and deal with a case narrative for an individual with multiple sclerosis, providing a pathways palliative care for multiple sclerosis. The case narrative here is based on a chapter in a forthcoming book called Mindfulness, Acceptance, and Compassion in Biofeedback Practice. Multiple sclerosis is a chronic and debilitating illness. It causes a wide variety of symptoms which are confusing for the patient and often for the physician. Blurred vision, muscle weakness, impaired motor control. The symptoms come and go in a remitting and relapsing pattern. The illness is often progressive with severe disability. Treatments are frequently only partially effective, and patients face confusing and frightening progression of their illness. The illness is mediated by changes in the central nervous system. The immune system attacks the myelin sheath surrounding nerve fibers in the brain and spinal cord. Myelin is an insulator, which causes the nerves to transmit more efficiently, like the insulation around an electric wire. Symptoms of MS will vary greatly depending on where the demyelination is happening in the nervous system and how severe it is. Environmental factors can also trigger exacerbation of the symptoms. We know that multiple sclerosis affects 400,000 persons in the US and about 2.5 million people worldwide. Onset typically between 20 and 50 years of age, and a much higher incidence in females, and that ratio of female to male occurrence is actually increasing. We don't fully understand that. The prevalence of MS is higher in countries which are farther from the equator, especially the northern countries such as the US, Canada, Europe, and Northern Asia. Two possible mechanisms are suspected. One of them is the high-fat, high-carbohydrate, and hypercaloric Western diet, and the other is reduced sun exposure farther from the equator and deficiencies in vitamin D. We know that there are genetic contributions, but they are multifactorial, meaning that there is no single genetic pathway. One gene locus at HLA-DR2 is very important in MS, but there are several additional recently identified pathways. We also know that such things in the environment as the intake of vitamin D, contracting the Epstein-Barr virus, or contracting a bacterial or a viral infection will interact with the genetic disposition, and frequently one of these causes seems to cause the actual first outbreak or will cause an exacerbation and return of the illness. Evaluating the patient is done by way of laboratory testing first to rule out other conditions which may look the same, such as Lyme disease. A functional MRI can also usually detect areas of demyelination in the central nervous system, but it's important to remember that about 5% of patients will show no lesion on their first fMRI. Spinal tap is also important because a spinal tap can detect abnormalities in the cerebrospinal fluid, such as an elevated IgG antibody level. Treatment is largely symptomatic, managing acute exacerbations of the disease with little hope of altering the course of the illness. Now, since 1993, there have been several new medications which are called disease-modifying agents. They have been approved for use, beginning with interferon beta medications, but they're only partially effective, not effective for some persons, and many patients still face acute exacerbations, time periods of much more severe illness. Because the illness is so unpredictable and because it progresses over time, about 77% of MS patients in one database turn to complementary and alternative medicine therapies, vitamins, minerals, non-vitamins, non-mineral natural products, relaxation techniques, and special diets. And now I'm going to give you a case study of a 36-year-old woman diagnosed with MS. Her name is Rachel. She experienced good health through childhood and into her late 20s. She showed an athletic, active lifestyle until the onset of the illness, graduated from a small liberal arts college and worked as a bookkeeper, and at age 27 joined an accounting firm. She also married that year and had 3 children, all daughters, within 6 years. Shortly after the birth of the 3rd daughter, she began to experience muscle weakness and blurred vision. Her symptoms were attributed initially to hormonal fluctuations. When the symptoms remitted and recurred several times, they went away and came back. The physician diagnosed stress or psychogenic related illness, but she began to recall previous episodes of visual and muscle problems at times when there was no apparent stress, and she began to question the diagnosis. After she had a full week of severe muscle weakness where she was unable to climb out of her bed, she was referred to a neurologist who ordered blood work, an fMRI, and a spinal tap. The fMRI showed 3 separate areas of demyelation of the nervous system. The cerebrospinal fluid showed elevated IgG, and the diagnosis was multiple sclerosis. Initially, she was treated with IV corticosteroids, followed by 2 weeks of oral steroids. The objective was to moderate the episode and the symptoms, and in fact, the visual disturbance and muscle weakness was moderated. She began long-term interferon beta medication to reduce the risk of recurrent episodes. She was also directed to stop breastfeeding during that first episode due to the risk to the infant of steroids. When she stopped breastfeeding, this triggered lability in her emotions and episodes of crying. We know that the disease process in MS can produce emotional dysregulation, including uncontrolled crying. Corticosteroids and interferon beta medicines also cause labile emotions. 3 years after her diagnosis and after several exacerbations of the illness, her primary care doctor referred her for behavioral health evaluation. She reported that she had almost no control over her intense sadness and her outbursts of sobbing. She understood that this might be because of her neurological condition and medicines, but she also believed she would benefit to reach greater acceptance for the losses accompanying her illness. She had lost her life as she had previously experienced it. Our initial assessment included the Beck Depression Inventory, where she scored as severely depressed, Beck Anxiety, which scored her as severe anxiety. She reported loss of confidence and competence in her accounting work, had to give up some of her key tasks to colleagues because she had trouble concentrating. She also reported much reduced physical activity with very few aerobic activities. She was attracted to the Pathways model, liked the idea of learning to take a more active role in her own care. She said she hated the feeling of helplessness, of waiting for physicians to solve her problems and then finding very little benefit. We assessed her as at the preparation and determination stage, readiness to undertake action on Prochaska's stages of change scale. So we began a Pathways model treatment with her working in dialogue to set her own goals. Her initial level 1 goal was to prepare more healthy foods. She decided to work on weekends when her sister was available and prepare healthy meals to be frozen and served on days when she was too weak or ill to cook. She also decided to set a goal of walking just 3 blocks to a nearby library and then 3 blocks home again, about 2 to 3 times a week with her daughter, whenever muscle strength allowed her to do this. She also set a goal to engage in mindful breathing. In the office, she learned with a health coach, relaxed, gentle diaphragmatic breathing with pursed lips, breathing at approximately 6 breaths a minute, and wrapping her awareness around the process of breathing, mindfully observing whatever unfolded. She repeated this exercise in the clinic at the beginning of each visit and then practiced it at home. She did well on her level 1 goals for 3 weeks, and then she suffered one of her exacerbations of the illness, severe. She was very grateful for the idea that she had stored frozen meals ahead because she could not stand, cook, or do household tasks for several days, and the meals were useful to her and her family. She continued doing her mindful breathing several times a day, which calmed her, even though she was having severe MS symptoms. She was unable to walk for 2 weeks, but she discovered that she could do upper body stretching. She had better motor control in the arms during that particular episode. And she resumed walking when the MS symptoms moderated. She committed to continue all of these level 1 activities long term, but she felt ready to go on and do something at a higher level. At level 2, she stated that she really liked the mindful breathing and wanted to learn more about mindful awareness strategies. She began listening to an educational CD on mindfulness from John Kabat-Zinn and read a copy of his book, Wherever You Go, There You Are. She also found a mindfulness class at a nearby church and enrolled in that class. Second level 2 activity, she undertook heart rate variability biofeedback, which is good for mood as well as better resilience, better coping with stress, and better coping with health challenges. She decided to do self-guided biofeedback as part of her level 2 plan and was able to purchase the HeartMath Inner Balance device, which works with a smartphone or tablet. The software guides the person to breathe at a pace which enhances large organized oscillations in heart rate, which is very therapeutic. The Inner Balance sensor monitors and moment-to-moment variations in heart rate and guides the person to a healthier heart rate variability. She also set a goal of doing some muscle rehabilitation work. Because of her intermittent loss of muscle control, she had given up most physical activities and sports. She was referred to a local gym and a personal trainer who had a background with exercise physiology and physical rehab. Finally, in discussing level 2 goals, she also expressed guilt about her anger and bitterness at God and her growing spiritual despair. So her team introduced her to a rabbi, Sarah, who had experienced painful illness and tragic losses herself and had shown sensitivity doing spiritual guidance with several individuals with chronic illness. Rachel attended mindfulness classes for 6 weeks and said that she felt she was forming a kind of a mindful bubble around herself, which buffered her against stress. She still had times of blurred vision, muscle weakness, and breakthrough crying, but she said it was like she was watching these events as if from a distance, which is a typical experience of improved mindfulness. She also embraced her biofeedback practices and felt her previous breath practices were flowing into and helping her with the heart rate variability practices. On the Inner Balance, she could now make large, smooth waveforms of changing heart rate across the digital screen in synchrony with her breathing. She also attended twice weekly sessions with her physical trainer at the gym, even when she was in a wheelchair. Her upper body control was much more consistent, so she worked on upper body musculature whenever she couldn't stand. The spiritual dimension was not so easy for her. She still felt an emptiness and a darkness about her life and the progression of the illness. And the rabbi invited her into a spiritual conversations group monthly with 6 other women with chronic illness. Now it was time for some professional interventions, and her first level 3 activity was a referral for nutrition. In her preparation of meals with her sister, Rachel had followed guidelines from the MS Society for dietary healthy diet for MS patients. At her request, the Pathways team referred her to a registered dietitian with training in functional medicine. And after extensive lab testing, she eliminated dairy-based foods, minimized her saturated fat intake, and increased foods high in polyphenols. She also added a probiotic, some vitamin D supplements, and DHA. Level 3, she also accepted a referral for physical therapy and muscle biofeedback. She suffered both muscle weakness and severe spasticity, spontaneous contractions of the limbs. She saw a physical therapist who prescribed a series of stretching exercises and taught her progressive muscle relaxation techniques. He also used muscle biofeedback to augment the muscle relaxation exercises. She continued to do well with the home use of the Inner Balance biofeedback device. She was able to breathe evenly, slowly, gently, and produce high coherence, smooth organization of her heart rhythms. Her therapist encouraged her to commit to 5 sessions of in-office biofeedback with the goal to identify the resonance frequency, the rate of breathing, which for her would produce the greatest heart rate variability. This is a widely used research-based model for doing heart rate variability training. And people going through this resonance frequency treatment frequently show improvements in medical and emotional condition. Her final level 3 activity, she wanted to do some kind of psychotherapy. She recognized her need to accept losses and changes in herself and her life. Her breath practices and heart rate variability practices, along with the mindfulness exercises, were already accomplishing many of the kinds of improvements that come from psychotherapy. So she was getting a kind of mind-body psychotherapy. She had reduced the physiological activation, muscle tension, emotional tone, and her negative inner dialogue. All of those are things that can be produced by mind-body practices, but also are goals within psychotherapy. For level 3, she committed to 10 to 12 sessions of acceptance and commitment therapy. Now, she chose this because this is based on mindfulness. The approach of ACT is to guide the patient to mindfully observe and accept distressing thoughts and feelings, not to dispute or combat the distressing thoughts, but to work at accepting, detaching, and observing the thoughts with acceptance. When she followed the dietary regimen, she actually felt less nausea, less heartburn, and better appetite. When she occasionally broke the guidelines, the heartburn and nausea came back, so she decided the guidelines were actually correct for her. Nausea at food smells persisted, but was less frequent and less intense. She felt progress in eating more regularly and feeding her family more nutritionally. With the physical therapy, stretching, and the progressive muscle relaxation, she had somewhat reduced her spasticity and the related pain, except on her worst days. She was also now more aware of stress-related muscle tension in her body and could identify triggers for her stress. She reported that her renewed attention to paced, mindful breathing and heart rate variability seemed to reinforce her overall mindfulness, and she was able to use both breathing and mindful detachment to cope whenever anxiety or worry struck her. ACT helped her to live her mindfulness more radically. She had never considered that accepting despair might be positive, yet as she focused on observing and accepting despair, the intensity of her distress went down. She finally decided that for a 36-year-old woman to live with occasional despair in the face of a progressive disease might be normal and reasonable. She shared her mindful practices with her spiritual conversation group and taught several of the women to utilize an acceptance mindset in their moments of distress. She also reached greater acceptance of the impact of the disease on her professional work and negotiated a reduction in her work hours and a shift to the kinds of work which she could do on a more flexible schedule. She shared the mindfulness practices with her husband, who was her caregiver. He learned several of the self-regulation skills, including breathing and basic mindfulness, and his stress level and moods were now improved, even when she suffered what she called a flare of MS. Under medical supervision, she discontinued her antidepressant and found that her moods were not affected. Her Beck depression score was significantly improved, high in the mild range. Her anxiety score was actually in the normal range, normal to minimal. Breakthrough crying still occurred, but she felt very different emotionally even when the sobbing occurred. She self-appraised that her MS condition was largely unchanged, with about as many days of visual disturbance and muscle weakness. Yet she reported a dramatic improvement in mood and greatly reduced subjective distress. Periodically, she recited the mantra that she had heard so often from her ACT therapist: OAA, OAA, observe and accept. Thank you.